warm welcome to our annual Congress coverage from ESMO. ESMO stands for the European Society of Medical Oncology, and on behalf of patients today, and Mamma Mia, Professor Kümmel and I attended this Congress and brought back the most important studies, which we would like to share with you here, or rather, Professor Kümmel will explain a bit about what it's all about. We'll then discuss everything together, and in this recording, now it's about HER2, new positive or overexpressed. You'll explain that again. Please introduce yourself, Sherko, and then explain once more exactly what we're going to discuss here.
So first of all, thank you very much, Alex. Firstly, for the invitation, and secondly, for the great teamwork together. Also in preparing the presentation and what we've brought along for you today. My name is Sherko Kümmel. I head the Interdisciplinary Breast Cancer Center at the Essen-Mitte clinics within the framework of a large women's cancer center in Essen. What we're going to discuss together today is HER2-NU. In the past, people used to say positive. Why do we now say overexpressed? Because by now, thanks to this TDX, trastuzumab deruxtecan, we've learned a lot. It doesn't just help when it's overexpressed. It also helps when there's just a little bit of HER2-NU positivity. But today we're focusing on the typical situation, HER2-NU overexpression, meaning the cases where we would otherwise use chemotherapy, with an antibody, trastuzumab, or with two antibodies, trastuzumab and pertuzumab, so the dual antibody approach, that's what we're going to focus on today. And now, to prepare you a little for this, or maybe just to get you to listen closely, both were so-called presidential lectures. What does that mean? Does the president show up? No, we will continue to focus on medicine at ESMO, presidential lectures. Means that when a piece of work, a scientific analysis, or a study is selected to be presented in the presidential lecture, it is strongly assumed that it will be practice-changing. And the first study that I will show you, I will present, is the one where trastuzumab deruxtecan is used, so to speak, in cases of HER2 overexpression, and these are always called the DESTINY studies here. That's simply the study name in all of this. And now we are dealing here with the two DESTINY studies, meaning two studies on trastuzumab deruxtecan were presented one after the other in the presidential, so to speak, session, as it's called in modern terms, managed to make it into the presidential session at ESMO in Berlin. So, and if all the attendees managed to find the room where they needed to go to hear it, it was completely packed, so to speak. There were several thousand listeners in total, so Berlin can handle such events, as you rightly said, almost 40,000 oncologists and specialists, industry, and
as a patient representative,
all the exhibitors from around the world, so to speak. Patient representatives, everything that was there, so to speak, finding it wasn't always easy in that complex, but we were...
Well, let's put it this way. The signage could have been better,
Yes,
but there was
absolutely.
enough space. And I also find it very impressive when I think 8,000 people can fit into that room where presentations are held. And there are still plenty of people outside who couldn't get in. It's really something special if you make it into this presentation. That's why we're glad that we were able to bring this here and present it.
So it's clear, we found the room, the two of us, we were right in the middle of it. We were there, so to speak. We basically brought it back for you, for all of you, what we're talking about. So to start with the disclaimer, my disclosures. Now we're going to talk about the Destiny 11 study. Sometimes it's worth reading the fine print at the bottom of the text. So who was actually the one who presented it? And it was none other than Professor Nadia Harbeck from Munich, who had the honor of presenting the Destiny 11 study in the presidential lecture. So for the first time, to show the audience worldwide something that could potentially change the standard in the future, if applied. So what is Destiny 11?
Of course, we can also cross-reference our takes on the topic of metastatic breast cancer, which are presented by Professor Harbeck.
There, you can see her live on video, where she will be talking about the metastatic situation. But here we will be discussing her presentation, which she gave on the early disease setting. HER2 is newly overexpressed in the early stage, so to speak. That means this classic neoadjuvant therapy, so chemotherapy plus antibody as the standard in all of this, or trastuzumab deruxtecan chemotherapy as a combination, that is sequentially, or just trastuzumab deruxtecan for these patients, so to speak. However, this was a patient group that already had a relatively high risk with positive lymph nodes or very large tumors. But again, as we also had, neoadjuvant. So if you operate first, you won't be able to use this strategy later. And I'll show you what this has achieved. So here, so to speak, practice changing, over 600 patients in total, and different strategies were used. TDXD, all these letter abbreviations, is this ADC, antibody drug conjugate. As we've already mentioned in other sessions, that's what it means. This is the new type of so-called chemotherapy. So we have an antibody, and attached to it is a chemotherapy agent.
Maybe you could briefly explain it again.
The chemotherapy is then called the payload. And this antibody targets HER2. So as we learned in biology class, as we used to imagine it, then there's a flash inside the cell and some kind of signal happens. That might not have been entirely accurate. Not that you need to discuss it again with your biology teacher at the next class reunion. In reality, what the cell does is it takes up this complex, and then I would say it's like a Trojan horse. Inside, this complex is basically broken down or digested. So the chemotherapy is released and destroys the cell from within and can then be released again to destroy the next neighboring cells, so to speak. That was more or less the basic principle of the first and second generation of the so-called antibody drug conjugates, for example, with TDM1. What makes TDXD even more powerful in this situation? There is a so-called bystander effect, because nowadays this type of chemotherapy is developed using AI-driven computers. These adhesives, these linkers, the antibodies, the payloads are also encoded in such complex molecules that sometimes when they dock onto the cell, they are already released. That means they affect cells in the vicinity of a heterogeneous tumor, which may not be HER2-NU positive, but can still destroy the tumor cell nonetheless in the whole process. This is called the bystander effect. And that is one reason why these new third generation ADCs, which we are discussing today, are so effective overall. So what was done in this 3-arm study? So classic chemotherapy with Herceptin or trastuzumab, pertuzumab, TDXD as just an ADC without additional chemotherapy, half of it in the whole process, or the combination, ADC and half classic chemotherapy. At some point during the study, it was found that trastuzumab deruxtecan alone is not effective enough. So in the end, only these 2 arms were analyzed. Full classic conventional chemotherapy with antibody or trastuzumab deruxtecan and half of the classic chemotherapies. So the main question, this pathological complete remission or PCR rates. So the number of patients in these 2 arms that were ultimately analyzed is 300 each. So a sufficient number of patients. High risk cohort, high risk, yes, in the whole group, meaning positive lymph nodes and or large tumors in this situation, or inoperable, etc. So now let's take a look at this. First, pathological complete remission, that is the so-called PCR. Here again, you see over 10% better, even in the hormone receptor positive group, where it's difficult to make a difference, 10% better. Hormone receptor negative, so the new strategy, ADC plus classic chemotherapy, is 16% better. So that's, well, I always think it's wrong when people say quantum leap because they think a quantum is a lot. But a quantum is actually very little, so I don't think the term is correct. A quantum leap is a small step for everyone who uses the term to mean it was a huge milestone forward. But that's what it is, you have to say. This will certainly become a therapeutic strategy for the future. And we see, not as a primary endpoint, but as another secondary endpoint, that this already pays off in terms of survival for the patient. So here, event-free survival. We see a difference here, so to speak, in this situation. Hazard ratio. Now, we've all followed several of our talks together, so to speak. What does less than 1 mean? So subtracted from 1, it means a 54% improvement when I use this new combination. And it's actually not that new for us because TDXD in the metastatic setting, as you might hear more about from Professor Habeck, has already become a standard therapy for us in various situations. That means we know how to handle it. So we're all hoping that soon, after perhaps approval-relevant situations, we will be able to start using such therapies as well. So a new strategy with a single medication, which we know from the metastatic setting and are well aware of how to manage. Very important, safety. We always have to keep an eye on the lungs. This so-called ILD, interstitial pneumonitis, which is not caused by infections, but by this TDXD. It affects about 10% of patients. You have to catch it early. Know that. If there is any suspicion, you have to order a CT scan, so to speak, and The treatment here also involves cortisone, that is steroids. So if you look at this, you can see on the right, this dark and gray area, side effects of classic chemo are not at all less than with this combination. We know that ADCs in general already are somewhat better tolerated than classic chemo, so not only more effective, but also the win-win situation of what we might call good oncological tolerability. If we take a closer look, so to speak,
there were differences up there, weren't there? Or did I see that wrong?
You can see here, this is this new type of presentation, so to speak, where you can analyze things well. Then you can see that the dark areas always represent the severe grades, where you see here 37% when I used the combination of chemo and TDXD. If I only used chemo, it's over 50% with more severe grades. Yes, that's why I say it's higher.
Oh, then I must have misunderstood just now.
So it's a win-win. Higher effectiveness and no higher toxicity, in fact. It's actually even lower. So you really can't ask for more. Then it was shown again that when you use only TDXD, many patients have already responded with what you could call a pathological complete remission. So almost 30, actually over 40%, but it will not become a new standard. That means we don't need to focus on it in detail today. So the combination of a so-called ADC, which we've just explained, and a classic chemotherapy improves and increases the pathological complete remission rate. We're already seeing the first trend, even an improvement in survival in this situation. And we are achieving this, I would say, better strategy, not with a higher rate of side effects, but rather the opposite overall. That means if it gets approved, we'll all be happy and it will be used. But so far, KVR has only been tested in patients with a higher risk profile. That's still crucial, depending on how the approvals turn out, how we will be able to provide it to everyone.
I find it really impressive that they say we're doing this now and there are fewer side effects. How do you explain that? Because I don't understand it.
With the ADCs like TDM1, which was already highly effective, we also saw fewer side effects. This Trojan horse that I explained earlier is of course targeted and naturally follows this backpack principle, so to speak, where the chemo is smuggled in this way, which of course results in somewhat fewer side effects than chemotherapy, which attacks everywhere and due to its nature destroys rapidly dividing cells. It also affects the mucous membranes and it also destroys other cells and so on. That's how it can be explained. That's why it also damages other cells and so on. That explains it.
Yes, and with that, we've once again shown that we've already talked about de-escalation, and that's again what people are saying. Now we have therapies that are simply much more precise in their targeting. So what's the saying? Shooting sparrows with cannons? That was yesterday. Now we're aiming exactly where the treatment is supposed to work. And as a result, we have fewer collateral damage, as I like to call it.
Yes, but still, ADCs are still a form of chemotherapy. I don't want to downplay that at all. They definitely have their own side effects and also signs of fatigue and so on. But what we've seen so far, our classic chemotherapy compared to this new combination, chemo and ADC, is definitely better tolerated overall. When you look at it as a whole, and it has higher effectiveness, but it's still always a chemotherapy, well, that will be with us for a while.
It's still always a step further in the direction that maybe at some point we'll move away from chemo altogether. That was also a discussion we've already had. Then let's take a look at the next study right away. It all goes hand in hand.
Yes, as we already said, presidential lecture, study 1, study 2, next Destiny study, and it's called Destiny 05 in this context. And it was presented by Jack Gallagher, who is one of the heads of the American study group, NSABP, so to speak. And here the focus was on patients who, after standard chemotherapy, still had residual tumor, which we know where we typically, so again, HER2 new overexpression, we started the tumor, which was positive. So during the surgery, there were still tumor cells present. And here, in many cases, patients also still had lymph nodes with tumor cells, so to speak, were still present as positive. These patients were included in the Destiny 05 study. That is, so to speak, what we have already shown and observed. And then the comparison is not the 4 times, as we did in the first, that is before, but instead TDM1 is given 14 times every 3 weeks. And now they compared. So the standard would be TDM1 from this. In the Catherine study, they compared it now with TDXD, that is ADC, as I explained earlier. Second generation versus third generation ADC. A fascinating question in all of this, with about 800 patients included worldwide, including in Germany. Again, the question in this situation is whether TDXD is better than our standard, namely TDM1, so older generation ADC versus the newer generation ADC. And if you look at the hazard ratio, they are all excellent, already trained. What that means is over 50% improvement. That is, it's a significant, and for me, that means practice changing in this situation.
Yes, so for those of you who may not have had the chance to see or review the earlier recordings yet, let me try to explain what a hazard ratio actually means. If 100% is represented as the number 1, then 47% would mean at 53%. So the remainder up to 1, there's an improvement, right?
Yes, so 53%, the new therapy is better. If it goes below
Yes,
1,
absolutely. That's correct.
if it goes above 1, the new therapy was worse. So in all of this, that's exactly right. Perfect. Very well explained.
Yes, I agree. No, actually, what I meant was the numbers themselves, not my explanation or the way I described it. But thank you very much for clarifying that and for your attention to detail.
No, but it's just as correct. That's why I said it again. We have a drug, ADC, which is now, let's say, first generation, and you can already see the progress. ADC, third generation. With the new ADC, we achieve a 50% improvement. If we look at the curves, here are the curves again. So overall, after 3 years of analysis, we already have a delta of over 8% fewer patients at recurrence if they receive TDXD. Again, which patient group? Neoadjuvant chemo, meaning chemo before surgery, then surgery. Unfortunately, still tumor cells present during surgery and in the lymph nodes, especially, or if it was an inoperable tumor, then TDXD was used, and then this improvement in this situation. Side effects, again, comparable. ADC1, ADC2 is not the classic compared to chemotherapy. But this lung disease, where I say you really have to keep an eye on it in this situation, since we've been using the medication for years, we're also used to how to handle it. Here you can see again TDM1 versus TDXD. Compared to the first generation, second generation, TDM1 already has a higher rate of side effects. As we mentioned earlier, compared to the classic chemotherapy, the side effect rate is already a bit lower. But compared to TDM1, it's somewhat more intense. That means if there hadn't been a survival benefit here, it wouldn't have become a new standard. So, a positive conclusion. In my opinion, absolutely practice changing. As always, there's a bright side and a downside. The study unfortunately only included this patient population. When we look at it, if we take a really hard look at it overall, 80% of our patients who still have positive tumor cells, not lymph node positive after chemotherapy, but who have these positive cells or, for example, inoperable residual cells in the breast. But the lymph nodes were then clear in all of this. That means we have to see how the approval will turn out. Here we see a clear improvement. We see survival benefits, but whether this applies to all patients who have a non-PCR, meaning not all tumor cells are gone, whether in lymph nodes and or breast, that is not known today. How it will be, so to speak, if it turns out exactly as in the study, then there is a certain number of patients who would still need to be treated with TDM1 because TDXD would not be available.
So that means it won't be investigated any further.
Yes, well, it's really no big secret. The WSG has also conducted a study of patients, including those without lymph node involvement and so on. We'll have to see what comes out of that. So in Germany, the West German study group, where a lot of patients also participated, so we'll see what comes of it. Right now, we can't say yet. We'll find out in the future.
That would be the logical next step, wouldn't it? Now we have those with lymph nodes and those who still had active cancer cells in the tumor remnant and in the lymph nodes. Then the next step would be to say, okay, now let's look only at those who have active cells left just in the tumor remnant. That's how I would put it.
So when it comes to ILD in the lungs, if we detect and observe it, then we have to discontinue the medication.
Very exciting.
But there are already, in many cases, triple combinations with anti-nausea drugs, that is, antiemetics, are used or even escalated further if needed.
Yes, that's really, really promising. And with the side effects, you're probably going to say, yes, I give Imodium acute, and then that's prophylactic. And then, or how do you deal with that?
Used prophylactically. But in metastatic situations, we've already gained learning curves and experience on how to manage this well. So you have to pay attention to nausea. But in my opinion, the teams are trained for this, those who use it regularly. And you have to pay attention to this lung situation. And if the lung situation arises, then you have to stop the medication and counteract it with cortisone.
Okay, so everything that could be managed was addressed as well. So now we're already at the end of our presentation on the topic of HER2 new overexpression. And I'm very glad that you once again took the time to select the studies with me to present these excellent and meaningful results. And on behalf of patients today and Mamma Mia, I want to say thank you very much for that. And I also want to thank our viewers. It's great that so many joined us again. And I'll just say until next time. Thank you very much. Goodbye.